Zoom lady. Today we have special guests joining us, including members of our evaluation team and members of Team Massachusetts. We have a jam-packed agenda for you, so let's go ahead and jump in. Next slide. On this slide, you'll find the usual housekeeping reminders, the most important of which is to mute your phone if you're not speaking. If you don't do it, I think that Bethlyn is going to do it for you. Use the mute button on your phone or press *6 to mute and *6 again to unmute.
Yep, and then the other thing, just to be clear too, if you happen to, if you're on your computer, when you hover down towards the bottom, you'll see a little microphone in the corner, and when that has the little red cross-off sign on it, that means you're muted, and then you can unmute yourself by tapping on that icon as well.
Thank you. Next slide, please. Thanks. On this slide, you'll find instructions for linking your phone and your computer under one webinar participant ID. This is really helpful to us when troubleshooting any technical problems, so please take the time to do so if you haven't already. We do appreciate your help on that. In the interest of time, we're not going to take a verbal roll call today, but instead we're going to ask that you enter your name and your state in the chat box so that we have a record of your participation. As you probably remember from previous calls, Zoom automatically saves a transcript of what gets typed into the chat box. So we'll be able to check your participation later without going through a verbal roll call. I see that there's some note here in the chat box that you're having a little trouble hearing me. So I'm going to switch to the phone receiver. I hope that's better.
Sounds good.
Great. Next slide, please.
Oops, 1 second.
So here is today's webinar agenda. We've already gone through our welcome and our roll call instructions. Next up, I'm going to turn the floor over to Bethlyn, who is going to lead us through some project updates, including some updates with regard to the on-site support visits. And our colleagues from Team Massachusetts are going to talk with us a little bit about their experience being our pioneers in having had their first completed site visit. Next, we'll have an opportunity for some team sharing. We have a couple of questions here for you, so if you have the chance to start thinking about these a little bit, that would be great. The bulk of our webinar time today is going to be spent with our evaluation team, specifically Chris Lewis. He's going to walk us through an update and some detail around the evaluation design, and we'll have some Q&A time for you all to ask any questions that you might have following Chris's presentation. And then we'll do a wrap-up and next steps. So that's the plan for today's time together. Next slide, please.
Great. All right, so I'm going to just take over here for a few minutes and just talk about our project updates. As I'm sure you all are aware, all the state teams are working either already in or moving into implementation phase towards the first cycle close of November 30th. We have, for everyone to be aware, we have our annual in-person National Advisory Committee meeting for the COIN is August 29th in DC. We also have a state team in-person meeting coming up. We'll do the evening of the 16th, and then we'll do a full day on the 17th, and then most of the day, I think to 2:30 or so on the 18th in Chicago, same as last year. And we are going to the next few weeks be sending out some logistical planning surveys for agenda suggestions, and the AAP will be coordinating travel for everyone, which will be fantastic. We have, as you heard from Meg, we've had one support visit completed with Team Massachusetts being our test site early on at the beginning of June. We are very grateful for that. And in July, we will be joining Team Washington and Oregon. And then we have teams Colorado and Alabama. And 1 second, I apologize. I can hear some background noise. I'm just trying to mute a few folks so that we don't have to worry about that if we can help it. And then in August, we had teams Wisconsin, Indiana, and Minnesota. So it's a full docket for the summer, but we're very excited about it. And everyone's been in the throes of planning and getting ready. And I think that they're going to be very valuable. And we, as part of family focus groups, there are materials now We've been adding to them, but there's now a complete set of things on Box as part of the upcoming support visit folder in the state team materials. And that includes, there was a training from Texas Parent to Parent that Team Texas has been using with their family leader interviewers for the family survey. And it's on, I'm calling it strong emotions, but grief and adaptation, stages of adaptation, and things that might be helpful if you're in a focus group and someone's some strong emotions are elicited, and how you might be able to work with someone and handle that in the context of the focus group. And we are more than happy to support and coach. Just reach out to Meg or myself, and we can set up a call with you beforehand, whatever might be useful. Just talk things through, whatever your, if anyone on your team, the family leaders who are taking control of the group, any questions that you have, logistics, in relation to the group itself, we're just providing that support role. We want to make sure that you have the opportunity to lead that, and so that it is truly authentically your team's process for making sure that you're getting information, eliciting the information from your families. So I think that's it for project updates. I don't know if anyone had any questions. We could put those in the chat box. Did you see anything there?
No questions yet, Bethlyn.
Okay, great. So I'm going to move on to the next slide. Just make sure I'm all right. So first, we're going to have Team Massachusetts has graciously offered to share out on their support visit and how that worked for them. Like I said, that was very early on, June 4th and 5th. So we were really grateful that they allowed us to use them as really kind of like we did our own mini PDSA cycles. We went in and worked with them and honed some of the process along the way, including for the focus groups. So we really appreciate that. And Mary Webster, I don't know if there's anything you want to say before Team Massachusetts takes over?
No, and I'm looking forward to hearing from them. I haven't talked to them since we've been, at least on the phone, since we were up there. We're talking at the end of the month. But I hope you, when you get on, if you'll mention about your logo there. I don't know if everybody's had a chance to see that. And then we'll get started hearing about that great visit.
Great. So Judy, I see that you're not muted. So I'd love to just hand the floor over to you and your team.
Okay. Well, thank you very much. It's an honor to have a chance to talk about the site visit and also to talk about the logo. This is something that we put together with our family consultants. The more that we thought about what the goal of the entire coin was, we kept coming back and back and back to the notion of family engagement in the most deep and important and really verifiable way. And so this logo really typifies that, and it also is something that reminds us each time that we talk to families about the little changes that are going on in the surgical preparation and then the surgical discharge. We want them to hear the word engage, think about it, really feel invited to engage. So that's the reason for the logo, and I think it's been very helpful in our coordinating with other parts of the hospital, nursing, surgery, and so forth. So if Bethany, you don't mind just going on to the first slide. We were very honored to be visited, and we tried to make this something that was both out-facing and in-facing, because I think there's one real advantage to a site visit, which is that when the site visitors come, it's a signal, I think, to our internal population that something special is going on. And so we used the program as an introduction, in a way, to the hard work we've been doing and what we'll be doing over the next few years. It's also a way, though, to speak more broadly with the larger COIN group, and we very much wanted to have Anna Maria Paquin from HRSA introduce and talk to us because she is our project officer, and it really was very, very helpful to have her start off the day. She came in on Zoom and really oriented us to where this particular large project sits on HRSA's agenda. And also was very reassuring that in these hard times, this particular project is quite protected. So that was very nice. We then spent some time really giving a little update to the site team about the nuts and bolts of what we've been doing. And then wanted very much to hear from the site visitors about the movement of the entire project and also their aspirations for the day. The focus group was really a large success, and we were very pleased with the preparation that was made for it. The leader of our focus group was one of our family members, is a young adult who just had a wonderful time and a great deal of learning for herself. As I mentioned, one of the things we were very eager to do was to make sure that we had our leadership, our hospital leadership, in on the day. And so Meg was nice to come on Zoom and to meet with Chris Landrigan, our division chief, and Joanne Cox, our associate division chief. And I think that was just absolutely invaluable for them to understand what's going on. And then we had an opportunity to talk a little bit of details about the KEDA and so forth. We debriefed, and then we had a lot of fun taking Mary for a walk around Boston and to Legal Seafoods, and so she could pick up some lobsters, and that was really great. Day two, if you can go to the next slide, I don't know if it will go on. Again, we debriefed a little bit, but then we had a nice opportunity for tour of the hospital and to do a Gamba walk with Mary. So Elizabeth is on, and she's going to tell you a little bit about how that went and how important that was for us in terms of the input that Mary gave. So the next slide.
Elizabeth, I'm going to unmute you so you can go right ahead. 1 second. There you go.
Can you hear me?
Yep.
Is that working? Okay, great. Hi, everybody. So I'm going to talk a little more about the main takeaways that we got from the site visit. So like Judy said, Sarah, our patient rep, had a wonderful time and got so much out of doing the focus group. So we thought that was such a great kind of way to include her more into our process. But also we had a great opportunity for Mary to do a Gemba walk with us. We started to recruit our first patients into our study. So she was able to see one of that process of recruiting. And the slide that's currently showing is some of the notes that she made for me to improve, how I, talk with families and introduce the study. And we got some really great insight on how to improve and make it better and, what was working. Another thing that was really helpful was going through our current processes with project management, and then getting more feedback on different ways to improve or different things to try. And so it was really good just to sit down and, kind of go step by step in our process and see what we could improve. And then the final thing that we really took away from this was sitting down and getting a better understanding and a better scope of what each of the different sites are doing, and kind of having a better feel for that. For those that didn't go to Chicago last year in our group, it was really helpful to hear from the BU team and just kind of have a better understanding of what great work everyone is doing. So we got a lot of really good information and experiences and stuff. And we really appreciate Mary and Bethlyn coming out and going through and spending the 1.5 days with us. So yeah, it was really great. So yeah, I'll put it back to you, Bethlyn.
Thank you, Elizabeth. I really appreciate you guys sharing some of the highlights. I don't know if anyone would have particular questions for it. Team Massachusetts, and Mary, if there's anything else.
Yeah, I do want to make one comment, and I think this is something that Judith and I talked about, just that I think we both, well, I know we both realized there was going to be a benefit to me as their coach going there and becoming part of their culture for the day. And I know I personally like to be able to see where you work and, what kind of constraints do you have, just walking around the campus and what that's like and what's the energy there and where are your support systems and what space do you work in? All that is very helpful for me as your coach to get to be more into your team and some of the wonderful things that support you as well as challenges that you may have. And then us just getting to know each other for more than just an hour at a time on the phone. So I hope that the rest of the teams that I'll be visiting and the two that Carrie is visiting will have that same experience and sense that as well. And the seafood thing is an inside joke, as I put out there. No, it is not a requirement of the site. Thank you, Meg.
Great. So I'm just gonna, so we wanted to open it up and see if, well, you're also still very welcome to ask any questions you might have of Team Massachusetts. And then just consider for team sharing things that you might be excited about in regards to your visit thus far and what questions you might have for each other, for us, as you're looking at what you're doing. What are some of the top things that come to mind?
Nothing in the chat box yet, Bethlyn.
Okay. Yeah, everyone's been working with each other on this, so there may not be anything, but we wanted to open up that opportunity.
When these are all said and done for this wave, we'll have a lot of rich qualitative data from each other. I bet you in September when we're together, many of you will be talking to each other about it and the positives and the challenges and things you took out of it and would want to do different next time or want us to do different next time. So all of that we're going to capture. And you do have an opportunity to fill out an evaluation after the visit as well. So there, it's just not that we just fly back out. We do actually care about your opinions and your input. And but first of all, I just want to thank each of you for working so hard to put this together. We realize this is not an easy task, and it can be nerve-wracking sometimes, thinking, "Oh my gosh, they're coming to visit." But please, note, and I hope you've figured that out by now, that we're just there for you. And, and we have nothing but great things to think about each one of you and know that you're working very hard. And it's just really an exciting opportunity for us to be with you for a day and a half. So we actually are really looking forward to that part. And even if we just stood around in a closet for 5 hours and chatted about your work, that would be great for us. But we know that you're going to love showing off. That's what we do. We like to show off our work and our environment, and you each have such great things to do. And that's all the stuff that we can take back to HRSA as well. So, and Anna Maria really enjoyed talking with Team Massachusetts, and she actually hung on a little longer than she was going to, and then she had to run to another meeting, but she was really getting into it too, wasn't she, Bethlyn?
Yeah, absolutely. I think it was great for us to get a deeper dive and have like a span of time to do that together. And it's kind of like, if you think about if you're working with someone and then you're able to see them in their home setting, it's like seeing in your setting, it tips different things. And seeing that context, it just, even in the conversation, different things came up. being in the physical environment where the work's being done and with you all as opposed to remote. So there is something that can't really be replaced in being able to do that. There are some things in the chat box that, Nandini, did you want to point those out?
Yes, so we got we got a couple comments here, but I'll start with the questions first. So we have 2 questions from Sharon from Wisconsin about the family's focus groups. So she's asking if Team Massachusetts could talk about more about the family focus groups and any tips and lessons learned from the family focus groups conducted through Zoom.
Sure. Well, we were so happy to have Sarah Perkins really invest in being the team leader for the focus group, and she worked with Bethlyn and with Meg for a couple of days ahead of time to be ready to facilitate the group. As you may know, the group is private, so we actually did not attend, so can't say too much about what actually transpired. We will get a report about it in the future. But in terms of the Zoom, oh my God, it just worked beautifully as I understand. And it was funny because I kept trying to offer people food because I'm so used to, giving food at focus groups and things like that. We couldn't do that, but otherwise, the VU team went to a great deal of trouble to get it set up. I will say that at the Boston Children's Hospital, we don't have every room set up beautifully for technology. And so we did go to a good deal of trouble to find a room that would support this kind of thing. And I actually would suggest that you take a couple weeks ahead of time to get the proper room, because that really did make a lot of difference, don't you think, Bethlyn?
Yeah.
You could see well and you could hear well. And
yeah,
so,
absolutely.
yeah.
Absolutely.
The interesting thing at Boston Children's is we have a wonderful room like that, but it's reserved only for parents. And somehow they didn't, they were actually, I'm just kidding, it was Eid and they actually were already booked, but, which is nice.
Yeah, it's a good problem to have. Yeah, I will say for us, this is something to consider if you're doing a virtual group, each individual person having their own computer. So Sarah and I ended up sharing, which worked out on the fly. We figured it out and we did what we needed to do to, and it was a lovely space to be able to be in. So we can definitely have it be like we needed to share on a screen, but as you can imagine, if you have another person or it just makes it harder to be able to just do the interactions and see people's facial expressions. So we can make it work for sure. And it did work. I just had to lean in to be able to be into the screenshot when I was trying to help clarify something that someone might have said or, but so that's something we could talk about if you're considering that with your group and how you're going to manage that part. So that's the one thing that, that I would say I noticed in particular when we did it, but everything worked beautifully, as Judy said, in general, the technology.
And Sharon says thank you. And from Ivy from Team Texas, she wanted to say that they're very eager to get input from national advisors and other key stakeholders local in Texas, but not part of our COIN team. And then Cheryl from Oregon says we're looking forward to the NAC consultations as well and meeting Bethlyn and Carrie in person.
Great. Yeah, I think that it's been really fantastic to see how the national advisors have been able to engage and I think that's I'm very excited to see how that helps propel conversations and projects forward from your perspectives. Ivy says, of course, we're looking forward to having Meg and Mary on our home turf. Don't want to leave that out. Very good. Well, we have a lot to cover today. Is there anything else anyone wants to say before we move out of our team sharing time about the support visits? Meg, you just shared a file, a folder file.
Yes, I'm going to explain that in just a second.
Great. So I just want to thank Team Massachusetts again for stepping up and sharing their experiences to kind of help people consider what the visit could be like for them. And I'm sure they'd be happy to answer any other questions that you might have along the way. So there you have it. And yes, we are ready to help and support with any family focus group operations questions or anything else you may need.
It was our great pleasure. Thank you.
Yeah, thank you very much. All right, so I'm going to move back to muting you, Judy. Oh, good, you got yourself. Good work. All right, I'm going to move to the next slide then.
Yes, please.
Great.
So, excuse me, before we turn the webinar over to Chris and company, we thought it might be helpful to share with you the conceptual model that we've been thinking about regarding the relationship between the HRSA required project goals and objectives and the data sources that we'll be using in our evaluation work to look for changes as the result of your innovations and interventions, and in relationship to questions that HRSA has for us about how the coin has worked, sort of process questions, but also bigger methodological questions with regard to COIN as a whole. If you'd like to reference this model or a roadmap while Chris is presenting, I've uploaded a copy to Box and put a link to it in the chat box. If you have a Box account, the link should take you right to the document after you sign in. We are just sharing this with you now as a preliminary taste of the kinds of detail that we're going to go into in just a moment. Please keep in mind while looking at this model or while listening to Chris that you will not be responsible for gathering and sharing all of the data that we describe. We know it looks like a lot, but please don't get anxious. As Chris speaks, your roles and responsibilities should become clearer, and we'll have time to answer any remaining questions that you have at the end of Chris's presentation. And we can always find time for you later if you have state-specific questions that you'd like us to address with you individually. Because the evaluation design is lengthy and one piece builds on the next, we're going to ask you to hold your questions verbally until Chris is finished presenting, and instead type them into the chat box so that we can follow up during the Q&A. So with no further ado, let me introduce Chris now. Bethlen, could you change the slide for us?
Great, thanks, Meg. Really appreciate it.
There we go.
I'd like, yeah, all set? Can you guys hear me just fine?
We can, Chris, and sincere thanks for spending time with us today. We all really appreciate it.
Okay, great. So I want to say a few words before we jump in here too, and I want to say that it's been a fun last probably 6 to 9 months as we've been really trying to build this evaluation design out, learning about all of the projects, meeting with several folks here at Boston University, meeting with a number of people and listening on a number of the webinars to really get a sense as to what's going on throughout all the states, and also working with Anna Maria and her team at HRSA over the last several months and getting their feedback on the evaluation design, which is now finalized, which we're happy to say, and we're able to provide this presentation to you guys as a follow-up to the office hours that we did to really start to have this conversation probably about a month, 6 weeks ago. And this is really, you know, the culmination of a conversation that we had with you guys at that point. So we wanted to bring this webinar to add just a little bit more color and depth to what it was that we were talking about in a little bit more of generalities at that point. Steve Fitton and I were on there, but today Randy Ellis is with us as well. Go ahead to the next slide. And we'll talk a little bit more in detail as to what the evaluation design looks like. And basically the way that I've laid out this presentation is exactly how it's going to look when you're able to access the full evaluation design, which I believe Bethlen has put online or in a Box folder already that you guys can go and read and share amongst yourselves. This is not a private document. This is something that you can look at and read in all of its gory detail to the point that you want to read through the methods and everything. But we're happy to use today as really a conversation piece to helping you understand what it is that's in the evaluation design, the reasons for specific questions, as well as our approaches and ultimately where we stand with each one of the states in collecting the data. Because I think that's a key part of the next steps to this is really accessing the data and getting that collected so we can move forward and really look at what's going on. And from my perspective, evaluations are not so much we're watching you and we're trying to find out how good or bad you did. I think this is really key about learning, and it's really learning about trying to understand what's working and what's not, and if it's not, or if it is, why is it working or why is it not, which is why we've really used a blended approach, a mixed methods, quantitative data analysis, as well as a qualitative approach in digging into doing interviews and focus groups and those types of things, and really learning from what's going on the ground level. So we're very excited about this. We're looking forward to it, and you know, what we're going to be doing throughout the course of the next 20-30 minutes is that we're going to talk a little bit about the evaluation team and our backgrounds. We'll start with that. We'll go over the objectives in the evaluation research questions, which are all very tightly linked. Talk a little bit about the data that's going to be collected, some of which most of which you know about already, and definitely we talked about in the evaluation office hours. The timeline, and then where we are with each state. So go ahead, next slide, please. One more. So here is just a quick breakdown of the experience of the evaluation team. Myself, I am a faculty member at Boston University School of Public Health in the Department of Health Law Policy and Management. And I've been the lead investigator on a number of similar evaluations here in Massachusetts, as well as in other states. New York Medicaid is another one. And I'm currently a lead in the PI for the Arkansas 1115 waiver that is just kicking off right now. So I've done this a number of times. All of these evaluations are mixed methods evaluations. But I think one of the most relevant pieces of information to each one of you is that I'm a former, I consider myself a reformed hospital administrator. And I was for about 10 years in various operational and strategy roles at numerous hospitals, for-profit, nonprofit, large, small community hospitals, academic medical centers, and as a consultant for a number of different health systems across the country. So very well versed at the challenges and the issues of implementation, and looking forward to learning from you guys as to see what's going on with these specific contexts. Dr. Ellis is also a member of our evaluation team, and he has number of decades of research in health economics and leading various types of evaluations as well as research studies. Probably one of the most senior folks in his field, and we're delighted to have him as part of this. I'm humbled and honored to work with him, and appreciative of that. And he is an expert in risk adjustment, as well as a number of different quantitative and econometric methods. And he also brings with him a great pool of doctoral students who work with him closely. And Miao Jing is one of those doctoral students who's going to be working with us as well. I'd also like to say that Steve Fitton has been a great piece of our team as well over the course of the last probably year or so since the beginning of this project, and has decades of state Medicaid leadership experience, and knows many people in the industry, and has been a great kind of a leadership member of our team, just in terms of helping us contextualize when we're talking about it from a research or an evaluation perspective. Well, what does that look like to the states, and how might that actually really impact them? So been a great addition to our team. And I will say that I asked him for a headshot and he respectfully declined. So we appreciate that too. Go ahead, next slide. Go ahead. So let's get into the objectives. You guys have seen these before. These are not changed from the NOFO or from the documents that HRSA had put out. These are the most updated program objectives, and they relate to the increasing the locus of management in a PCMH, or a patient or family-centered medical home, increasing the number of CMC, children with medical complexity, in a shared plan of care, increasing unmet need, and or the number of families in the cohort reporting unmet needs are being met, as well as the number of families and the cohort who report being engaged. And then finally, looking at who has implemented an innovative payment model. And I think that's been an interesting one for us to start looking at as well. So these are not changed. The other thing that I want to mention here, and it was previewed briefly in Meg's slide that preceded this presentation, and you know, HRSA is interested in the overall impact on costs with respect to these children with medical complexity and what these initiatives are doing. And that is a reason that we have built in a number of research questions. On the next slide, you can go ahead, Bethlyn, and really started looking at cost and utilization and trends in patterns of usage from these children and what's going on with their health care. We also, in addition, and on the next slide you'll see in just a second that we have very specifically looked at those program objectives to tie in whether the activities of the states are meeting or exceeding those numbers. And frankly, we're not, from an evaluation perspective, stuck on, at this point, did you make 50%, did you do this? We're really interested in learning as to where we made progress, why did we make progress, or why did we not? So we're not getting stuck on whether it's actually 50%. We will look at the numbers and look at those things at the end, but for me as a researcher, you know, really looking at this quantitatively and then trying to dig in and understand qualitatively why certain things happened or didn't happen is really what's interesting. So I use that as a little bit of a springboard into the evaluation research questions, which we've laid out in a number of different areas. And I'll also say that if you hang with me just for a couple of slides, we also do connect these with specific data sources. So as I read through these here, be thinking about what is it that we're looking for, why might we be doing that, and then how might we collect data related to these things. And from my perspective, there's a number of different ways that we can do that, but we have tried to articulate where we can, where these evaluation research questions tied directly into specific data sources. And as you'll see, some of them are quantitative, some of them are qualitative, some of them are survey data. So, you know, if you look at the first couple, these are really from administrative data, you know, what were really descriptive, really looking at what were the interventions, when were they phased in, really getting a foundation for what's here. And then looking directly at the innovative payment models that were implemented. And one thing that HRSA was really interested in, I think is a good point, is not just did they do it, it's what were the specific approaches. So that's a really a quantitative and a qualitative couple of questions right there. And that's something that we're interested in digging into. It's not really the whether, it's the what did they do and how did they do it. So we're going to have to do some interviews to really learn a little bit more about that in those states that elected to do this. The next couple of questions are really looking at utilization and the services and the providers and relationships or patterns related to care management and utilization. And I think those are important questions that we're looking at on the health economic side or on the quantitative side, because we really want to know about patterns of usage. And that's really what many of these questions really look at. And were there changes in usage over time? Were there changes in utilization with these children? And what might have been the reasons for that is something that we can then dig into qualitatively by talking with you guys later. And then, so directly if you look at number 6, how do utilization patterns and claims data change in response to the COIN innovations? That's a very direct question. And it's going to require, you know, an intervention group or as we're calling it, a treatment group. And the control. And claims data is really the best way to look at that. And we'll get into that a little bit later as to the types of data and the things that we need to really look at that, because it is possible to do. It's a little bit easier in some states than others, just to be clear about that. But I think it's very possible in each one of these areas. So go ahead to the next slide, Bethlyn. Again, number 7, we're really looking directly at usage of healthcare and the healthcare utilization rates related to ED and readmissions for these children, and then avoidance and some other areas as well. 8 through 11 are really directly related to the program objectives and looking at whether there was a percentage change and or how they directly related to those questions that were in the or the program objectives. And these are going to be looked at with the survey data pretty directly. We'll talk a little bit more about that later. 12 and 13 are really more qualitative questions, and 13 arose because of our conversations with HRSA that were, really well developed, I guess, ideas from them or issues for them that they really wanted to know about what part of the methodology worked. And I think this is a really good place for us to really dig in and talk with folks from the state over the course of the next couple of years at multiple points, just briefly about what do you think is working? What part of the methodology is working? What was the easiest to implement? What was the hardest to implement? And if something didn't work out, tell us why. And so this way it can inform future COIN initiatives or different types of grant programs that they're going to put into. And I think this is a nice way to really learn from the folks that are doing it. But we're also going to be, really looking at those in number 12, the conversations with the families and the who are there really with the children with medical complexity who are dealing with some of these issues. So I think that's it for the research questions. I think you can tell that we've got a nice blend of quantitative and utilization-based ideas that we're going to be looking at, as well as speaking with individuals from all different types of perspectives. Go ahead to the next slide. So let's talk a little bit about the data and the data needs that we're going to be really looking at over the course of the next probably year and a half, and or actually throughout the end of throughout the duration of the program. So first, let's talk a little bit about the quantitative data. So there are a number of types of quantitative data that we're going to be looking to get, mainly related to Medicaid and or all-payer claims data, depending on the state. Some states are further along in actually getting all-payer claims data together, and where those data sources or where those data sets are mature, we're going to look to use those to actually be able to identify and use in our analyses. And those will, in the other states, we're going to be looking at even just the Medicaid claims data will give us a good picture as to what's going on with utilization and trends with these children. And specific to those quantitative data sets, we're going to be looking at claims data, eligibility data, health plan data, quality and performance measures. All of these things will give us a slightly unique perspective as to what's going on with these children. And I think that it's important to note that we're in the initial document that we may have shared, it may have said that there are 3 points of data or 3 data transfers that we're looking at. But as we've really dug into this, these become, when you're buying an all-payer claims data, they become costly. They also become very time-consuming, not only for the states, but also for us. So we've actually, given that we're, not quite halfway, but halfway-ish along the way here with this project, we feel that 2 data transfers from each state is probably going to be fine. The first one is really going to be helpful in identifying, well, what are we looking for? What do you have for each specific state? And as we all know, that each state has a slightly different data dictionary, the way that the data is housed or presented, and the way that Medicaid or the all-payer claims data is organized. So we have to really work through with each one of the states. How does that look? What is it? What structure is it coming from? And data security and all those things to make sure everybody's comfortable with these types of arrangements. So I think that the idea is that the first one will really be getting the kinks out, and then hopefully a lot of the process will be just for lack of a better term, a point and click on the second time when we have the new data from the second half of the intervention or from the program. And this way, it's a little bit easier the second time around, but it's closer to the end. So this way we can really evaluate what's going on. The second type of data is the survey data, which I believe, and Meg, Bethlen, just shake your head yes or no. I believe everybody is well versed as to what surveys are out there. I figured that. We're hopefully going to be getting about 40 responses a couple of times a year from each one of the states. That may vary a little bit by state, but they have a number of different key pieces of data in them in these surveys that we're going to be looking at on a descriptive basis. I guess one of the other team members or entities that's going to be working with us is really here at Boston University. It's our Survey Research Center that is going to be doing the descriptive analyses and working with me closely on that, as well as Meg and her team. So when you guys provide the data, we'll have a clean-cut process for trying to look at that, organize it, and be able to tell what happened from it. And then the last part of the data is the qualitative data, which is, from my perspective, one of the richest parts of this evaluation is really talking to people. There's going to be a couple of points where we're going to look to speak with 3 to 5 members of each state team, just via phone, short half-an-hour conversations, half an hour to 45 minutes, and just to try to understand what's going on and directly related to those research questions that I talked about before. And specifically to look at the assessment of the COIN methodology and the processes and what's working and what's not. And then also there are focus groups with the family members of the children with medical complexity about quality of life and family well-being that are ongoing, I believe, at this time already. So, or if not, they'll be starting. Meg's shaking her head yes, so I believe those are already going. So, and then we're only really going to need one focus group from each COIN on that to really get a sense as to how things are evolving. So, so those are the 3 data sources. We have some quantitative data. We have some which is really based around claims and enrollment data of these patients. The second is the survey data, and then finally the qualitative data, which is really interviews and focus groups. Next slide. And here is what I alluded to before. I don't want to spend too much time on this, but you guys can look at this at your leisure. It's really just a table to help organize based on each research question where we anticipate getting the data to answer the question. So for example, the first 2 research questions come from the administrative data. We know that much of this already exists, but we're going to have to look a little bit closer at some reports and documents that have been submitted by the states, just to understand a little bit more about the, especially specific to number 2 and related to the innovative payment models. We'll also ask some questions when we talk to you guys on the qualitative interviews as to what's going on there. The next few, so number 3 through, if you go to the next slide, really come from the claims data, 3 through number 7. And we're going to be digging into those state data sets that we get from you guys to really look at what's going on there and the utilization patterns, et cetera, and the referral patterns and other things. Number 8 through 11, as I mentioned before, are strictly from the survey data, and then we have a couple at the end that are focus group data. So this is a little bit easier. Basically, what I've been talking about all along. This is a table that provides you the context as to where we're going to get this information from. Next slide. All right, so I don't want to go into too much depth here with the methods because I think the evaluation design gives a very, very detailed look as to how we're going to approach these, the analytics of these, of answering these research questions. Here, the quantitative methods really were devised by Randy and Dr. Ellis, and he's going to be performing a number of really core modeling techniques on the data. We're going to establish an intervention and a control group. And as I talked about before, this is really important here because we need to know where how these children with medical complexity are comparing to comparable others within their states. And we understand that these interventions, you basically have 10 natural experiments, and we're going to handle each state data set individually first before looking at them across states. So know that we're not going to be just immediately pulling information and trying to make comparisons with intervention and control groups that are not alike. And I think this is going to take quite a bit of thought. But within the evaluation design, we talk a little bit more about how we're going to do that. And I think that each state has a little bit of a unique approach to that. But I think using something like propensity score matching, which we have outlined here, will help us do that to make comparisons across the groups and then look at those things. Randy's also going to employ time path event studies as well as risk adjustment. And this is something that HRSA really was interested in, and it's something that Randy is, as I said before, an expert in. I'd like to make a note here too that the way that the IRB is set up is that neither Randy nor Steve or Miaojing or I are interested at all in seeing patient names in any way, shape, or form. We believe that it's much better for your IRBs and confidentiality that if you're working with your state agencies or your state partners or the all-payer claims data people, to do that linking behind the scenes without us involved, because and frankly, it's better for confidentiality of the patients. When the data comes to us, then either from the state agency or from your state Medicaid agency or from the all-payer claims data folks, it's already there. There's a unique identifier or a flag that says this patient is in the population, in the treatment group or the intervention group, whichever term you prefer. And that lets us know that we can compare that person. Let's look at their characteristics with what's going on with somebody who has similar characteristics. And that's kind of the way that we'd approach this here. So I just wanted to make that clear that we're really not looking for patient names and those things, but there have been a number of questions along the way as to some states feeling a little bit uncomfortable about transferring that data. So I just wanted to make it clear on this webinar that we're not interested in having that data, and we're happy to have conversations and help answer questions to allow your teams to, when the time comes, to process that data and pass those names along to your state data agents, or to your state agencies that are going to be doing the data linking for us. Next slide, please. So the survey analysis, talked briefly about this. I think many of you were involved in the collaboration that essentially created the survey. Many of the questions were already tested, and a number of the domains in this were already existing. So wherever we could actually take pre-existing survey content or questions, we did. A number of those were taken verbatim from those other surveys and put into these. Some were tweaked a little bit. And then there were a few questions that were added. And if you you don't have to move the slide at all, but if afterward you're back a couple of slides after this and you're taking a look at it, you can see a bunch of the different domains that we've plucked questions from and created this survey that has 40, 50 questions on it. And many of you know about the survey already. These will be done either by phone, in person, or web-based survey by trained representatives of each state team. You guys are well aware of that. And then there will be, on our side, once we receive the data from the state partners, and I believe what happens is you're going to be sending just some raw data to Bethlyn and Meg and their team, and then they're going to be providing it to or it's going to go directly to our BU survey research people, and then they'll be performing just descriptive analysis on this with mean and median responses available. So, and then finally, the interviews will be conducted with, in talking about the qualitative data, will be conducted with a member of the evaluation team or the administrative staff, and we'll provide more information probably the last quarter of the year on this one. It'll be, we're anticipating doing some of these interviews for the first round in the first quarter of next year. So we've got a little time before we're going to be really getting into speaking with you guys, give you a little more time to get into implementation, see how things are going, and then we can really get a little bit more from you. We'll probably do a second round of interviews, follow up in the same 3 to 5 interviews with folks around the final quarter of the project period. And this way we can see what your plans for sustainability are and for some other things as well. So a couple of rounds there, but again, not very onerous, just a half an hour, 45-minute conversation with 4 to 5 of you guys, preferably individually and done by phone whenever possible. If you're close by, if you're in Massachusetts, we might stop by if that's easiest, but phone works as well. The focus groups will be audio recorded and transcribed by an independent third party. We don't want any part in the transcription. We want to make sure that's done independently. And then we'll use directed content analysis. We'll have a pretty standard approach for looking at those. And the way we're going to present results here is based on an aggregated thematic finding. We're not going to be quoting anybody. We're not going to be doing anything like that. We will make the final results available with Anonymous. If there's interesting quotes or things that we've learned, we'll add them, but no one's information will be able to be basically tied to them. They will just be exemplary and I think help support the themes that we found. Next slide, please. So a little bit on timing, and looks like we're at about 3 o'clock too, so that's good. I'm doing good here. We've got plenty of time for questions afterward. But quantitative data, we are going to be looking to, we're basically already in this process, and many of you have spoken with either Steve or you came to the office hours. We're really going to be over the next 4 to 6 months really trying to get a number of requests out, formal requests to specific states now that the evaluation design is completed and DUAs, data use agreements, are going to be needed to be signed and moved on to formalize this process a little bit more. For example, we've spoken with Colorado, and they have a pretty mature all-payer claims database. They have a series of forms that we have to fill out. So that's going to be one of the things that's top on our lists moving forward. And then the first data transfer from each state to BU, we hope, is no later than the last quarter of this year, first quarter of next year. So this way we can start working with the data to really see what's in it and learn. Because as I said before, each of these states is going to be a little bit different, and we have some resources that we are already on board waiting to use the data. But we want to do this the right way. We want to make sure that you guys are comfortable with what you're sending and that we know what we're getting. So, and then again, like I said before, the final data transfer will come toward the very end of the evaluation program period, and we'll evaluate the exact dates of that when we get there. But hopefully those are easier, given that we have the learnings from the first data transfer with each of the state Medicaid agencies or the all-payer claims data providers. Survey data, that's going to be transferred twice a year to the BU team. And ideally, we see those after, the Boston University Survey Research Center has a period of time where they can, work with the data and get their forms and their processes completed and kind of streamlined. And then this way we'll get routine updates on that and provide insights as to what's going on with the survey data and how, and kind of on an ongoing basis, what we're learning and where we're growing and what's not improving. And then finally, the focus groups are currently underway. In the first quarter of 2020, as I said before, round 1 interviews with the state team. These are going to be really focused on your implementation efforts. And then in the second or third quarter of 2021, kind of toward the end of the demonstration period, we're going to be doing follow-up interviews with some folks at each one of the states, the leadership and state teams. And we're going to be doing some, really focusing on lessons learned and sustainability efforts. Next slide. So I'm going to leave this here for you guys to take a look at, but I just wanted to make a note, and Steve Fitton has been very good about keeping us updated as to what his conversations are going on with each state over the course of the last year about where their processes are. We've also done some background research on our own as to which states have all-payer claims data. So we have an update here for each one of the states. To varying degrees, we're having really good discussions with some. In some states, we've had a little more trouble kind of getting entry into who is even the right person to talk to about accepting or having conversations about how do we get access to Medicaid data. And I think, we've got some really good legs in states like Minnesota. It seems like by the end of the year, we should have information from them. Colorado, we're comfortable with. There's a number of states that we've had excellent communication with, and we appreciate that. And we're looking forward to working with the others a little bit more closely over the next few months. And we'll probably have some more dedicated resources on this end to help drive that as well. Be a little bit more proactive about following up and communicating with you guys, just so this way we can start getting the data acquisition process, which is really key for us over the next 6 months or so. Keeping that moving, but this is just kind of a snapshot as to where we believe in lay terms each state is at this point. And if you go to the next slide, really really the next steps for us are to continue to work with you guys on this. And I'm happy to set up individual calls with every state or with each state team with either Randy and Steve and I to talk about what it is that we need to give you to gain access to getting that data. We know many of you guys have really good relationships with your Medicaid agencies, and we don't in any way, shape, or form want to infringe on those. We actually want to help support that and provide you information. And hopefully the evaluation design will start to do that a little bit more formally than we have in the past. But I think it took a while to get here because we wanted to make sure that all of our partners, HRSA included, were comfortable with what we were going to be evaluating. And now that this is here and the methodology is intact, I believe that we can, provide a greater level of detail to these Medicaid agencies that if you have to go through in front of a board or some type of data review committee with the state Medicaid agency, that you have the information that you need, that or we can be on a call or something with them, that we can really talk clearly about what it is that we need and why. So I think that's where we are. And each one of these next steps related to the focus groups and the surveys is really just a rehash of what we talked about already. But go ahead to the next slide. I really wanted to say that before we open up for questions, I've enjoyed working with everybody, again, both on our team as well as the other teams, and from all the states, and learning from the folks at HRSA as to what's important to them. And I feel like we've got an evaluation design that really blends each one of those perspectives. And I'm really looking forward to carrying on these conversations. And before I open it up to questions, I know Randy's on the phone here, and I want to see if he has any, him or Steve have any last minute comments before we open it up to questions.
I'm hoping you can hear me. My name's Randy Ellis, and Chris did a great job summarizing the ambitious evaluation plan that we've set forward. And I think you can see there are many questions we're trying to answer and at least 3 broad sets of data to gather. And what will make this work is having your side be enthusiastic at prompting the Medicaid or possibly other groups such as all-payer claims data to be enthusiastic about this whole process happening. And I'm excited about the survey getting underway, and we'll be looking forward to seeing the early returns on that as well. I'm a methodologist primarily. I've worked a lot with different data sets, especially early work on Medicare and a lot of work recently with private insurance claims, as well as some exciting work with Arlene Ashe in Massachusetts using their all-payer claims data to look at some Medicaid risk adjustment issues. So I've also done work in the state of New York on looking at the medical home, patient-centered medical home implementation of a couple of health plans. So I think there's lots of lessons to be learned, and this is a very ambitious and exciting project to be part of. So I look forward to answering questions now.
Steve, anything from you, Steve, on following up from my presentation here?
I just enjoyed my interaction with the various states, and I think we've had some very productive conversations and are moving forward quite well in most of the states, as you indicated, and so we'll just continue to look forward to working together.
Great, thanks.
So that's it.
Great, thanks, Steve. Meg, how do you want to handle this from here? I'm looking in the chat box right now.
Chris, this is Nandini. We do have a question from Mary from Team Indiana. She had asked, do you have a list of the factors you will be using in creating the comparisons, such as age, race, county of residence, diagnoses, utilization, and costs?
Randy, would you like to take this one?
Sure. This list will depend on what programs and activities your state is implementing. There are 2 sides to it. One is just being sure we can identify who has actually experienced a a reform or a treatment process to create a treatment group. And conversely, people who haven't been eligible for the treatment process or activity, which will be part of our control group. But that's the most elementary, just getting administrative data on that. The second is just trying to create a balanced comparison. So, if one group is much older than the other or much sicker than the other, that's where these lists that is shown of age, possibly race, county of residence, diagnoses, and utilization or costs could be used. I'm a big fan of trying to match on diagnoses and possibly procedures to identify children who have some similar, problems with medical complexity. So that will be important along with age. And, we wish there were a larger list of things like education or income or family characteristics. But typically that is not easy to get. I would be delighted to get county of residence as a geographic adjuster. We were able to use information like that in Massachusetts for an earlier project, but I know that's on the boundary of what can be feasible in many states because of identification confidentiality issues. So we're not assuming we will get that. And there's been some very exciting work done by myself and others at Harvard who have been able to match across diverse samples by drawing similar looking people even from different samples. So if you have a sample that is in your treatment pattern and you know a fair bit about them, then you can try to find others in your control population who look very similar using propensity score matching and also risk adjustment models, my area. But that's basically, I don't know if that answers your question, but we will be using clusters of diagnoses and also possibly people who have had major surgery or, events in their life. It could be an accident, it could be a burn, it could be whatever disease process that's critical that might be signaled by procedure information.
Great, thanks, Randy. We also have another question from, I'm so sorry if I mispronounced your name, Gemma Warner. She's asked, please describe the methodology to be used to define the control groups. Who will be involved defining the control groups?
Okay, I think many of the interventions will be of the following type. There will be either one clinic or one region may implement some innovation or reform. And so in that case, geography or distance to that available clinic or set of providers would be one of the important ways of defining a control group. In other cases, it may be a statewide innovation and there will be eligibility criteria since not everybody can be eligible for the program. And in that case, we would be trying to look for other individuals who might be similar in important ways with the treatment group to try to match with the controls. So I know that sounds very vague, but basically it's going to depend on working with your team to identify the characteristics that define your program and then use that to select individuals that will be used as a control.
Great, thanks. Thanks, Randy. Appreciate that. Looks like there's a question about our process around data use agreements and how we will support the states in that. I think this is a joint process that every state is going to be different. So each state agency has information or standard forms. I know that the state Medicaid agencies that I've worked with in the past have their data use requirements that we have to meet, all of which we pretty much can. At BU, we have good, flexible folks that work with us to set up the data security and how we're going to access the information. But many of those forms are already preset from each one of the state agencies, and we really work with them to complete their forms and on an individual basis. So our process is really to look at what those forms are and what the process is for each state. And then we go from there with creating the process that works best for data security and how we're going to house the data, what we're going to use the data for, et cetera, et cetera.
Yeah, Chris, if I can,
Yeah.
this is Steve. I just want to jump in and say that in some of the states, we've ended up talking directly to either the Medicaid agency or the agency that is in charge of, you know, the repository of data that the state has for whether it be for Medicaid or an all-payer claims database. And we don't do that to cut off the project team from being a part of that process. And certainly we try to keep the project team connected, but we don't just sort of leave you with the whole task of trying to figure that out. So we do jump in there and provide assistance as necessary. Some states seem like they're connected very well, and other states, you know, maybe they have a little less experience with those processes, but we will provide support and be a part of that process to make it work.
Great, thanks. Randy, were you going to jump in there with something too, or?
Yes, I was just going to say that their Boston University has a secure data center in Western Massachusetts that is being used for very large data sets that has appropriate guarantees of security, and that is a very important process. I personally have not used this myself, but I know others in the School of Public Health have, and that will be the conduit that will satisfy the states to ensure security.
Great. Are there any other questions for us that we can answer at this time? You know, don't feel like you have to, if you're looking through this document next week or something, we're happy to set up a call with you guys over the course of the next few weeks to really allay any concerns that you might have, or continue discussions with your specific states. Again, I'd like to stress that this is really important to get off to a fast start with these things, but not only to get off to a fast start in getting the paperwork done, but also knowing what it is that is going to help the process, both on our end and your end, so we don't have to do rework, you know, 4 months down the line, and this way paperwork isn't done correctly the first time. So the more questions you have for us at this point, and as we move through this, the questions that we have for you guys, the earlier the better, and I really appreciate everybody's support in that too, as Randy echoed before.
Nothing in the chat box yet, Chris and Randy.
Great. All right, I think that's it.
Thanks so much, Chris. We really appreciate the time and effort that you put into putting together the presentation, and thanks to Randy and Steve for their for their contributions as well. I also wanted to say special thanks to Team Massachusetts for being our on-site consultant visit pioneers and sharing a little bit about their experience today with the state teams. Please don't hesitate to be in touch with us if you have follow-up questions. If you have state-specific questions that you wanted to ask of any of the evaluation team, I can certainly make that connection with you and get you all connected via email. So with regard to our next steps, please reach out with any further questions that you might have on this or any other topic. We are happy to be helpful in any way that we can. We're going to all continue our support visit prep. I feel like everybody is up to their necks in that right now, and it's very exciting, but it's also a lot of labor, a lot of work. I wanted to let you all know that while we are going through this process, these are our first support group visits for this particular project. And while we're going through the process of setting up this year's, we're also keeping a running list of things that we want to improve for next time around. So we will be reaching out to you for ideas around that, but please don't think that we're not thinking of it as well with our partners at Improvement Partners. We're going to review data collection and management processes during the support groups if you want to. So if you'd like to have that as an element in your support visit, please don't hesitate to put that in your agenda. Refer to Box for examples of support visit materials, such as other states' agendas as they're developed. We'll be uploading those so that hopefully you can use them either as models or at least as places to jump off for ideas. Contact us with ideas for objectives and useful elements at the in-person meeting in September. We'll be sending out a formal survey to collect your ideas about that in the next few weeks. But in the meantime, if anything sort of jumps up at you, especially in the context of designing your on-site consultation visit agenda, that you would like to suggest that we include as part of the in-person meeting in September, something that you would like to talk not only within your own team internally, but with some of the other teams as well, either on a specific topic or a specific challenge, please don't hesitate to be in touch and let us know about that. Next slide, please. As always, here is our evaluation link, and we very much would like you to fill that out and send it back to us. We do read your evaluation results very carefully, and we use them to improve future webinars. So please take the time to do that. It's a very short survey. I think it's a total of maybe 6 questions, and it shouldn't take you more than 5 minutes to fill out. Nandini, Nandini has anticipated what I was just about to ask. She has put a link in the chat box, and so you can click right on that and get access to it. So unless anyone had any last questions that they wanted to ask or any last comments by any of our presenters or Bethlyn, was there anything that you wanted to say and wrap up?
No, I just, we will, if there's anything you think would be great for us to continue even with this conversation, either in your support visit or at the onsite. And one of the things to recognize moving forward, we're really going to try to really highlight more of your experience, expertise, learnings. So thinking in that frame too, for what might be useful to you or that you feel like you might be able to offer even for the onsite is just something to consider, and kind of we'll guide you in some of that as we present the survey to you in the next few weeks, but just to get you percolating.
Thank you, Bethlyn. All right, it looks like we're going to return about 15 minutes to everybody's day. We won't hold you up. Thank you again for your attendance and for your good questions. We'll stay in touch. Thank you again to the presenters, and I hope everyone has a great weekend. Take care.
Thank you. I'm going to leave open for just a few minutes for anyone that wants to grab that survey link, and then we'll be done. Enjoy your weekends.
Thank you.